Good evening, everyone, and welcome to IVF webinars by Egg Donation Friends. Let us know if you can hear us properly, if everything is working. I will be grateful for this information from you to have. So just let us know in the chat section. Today we are here with Dr. Francisco Anaya from Pregnant Reproduction Unit in Clinica Vista Hermosa. And today's presentation is implantation failure and egg donation. We changed the topic a little bit, but I'm sure that you will be interested in it also. All the questions which you can have also about miscarriages, you can type them already in the chat section, so feel free to do that. The presentation will take about 25 minutes, and Dr. Francisco Anaya will dive into the topic, and then right after that we will follow with Q&A session. Let me remind you that this webinar is being recorded, and you will be able to watch the recording on our website tomorrow, and there will be also the transcriptions of Q&A session. This is the subject, implantation failure and egg donation, and if you are ready with the presentation, that's all from me for now. So, Dr. Anaya?
Okay, so I'm going to start. Good evening to everybody. We're going to speak this afternoon about implantation failure in reproduction and when we should consider the possibility of resolve this problem by a gamete change. Successful implantation is a complex process involving two main players, the mother as a host and the embryo. Implantation failure is one of the most complex and frustrating challenges both for professionals of assisted reproduction and for patients who suffer it. It's an issue that is being in the focus of investigation, and we can see many publications in the last few years. We know much more about this process now, but we're still far from being able to solve all the problems. The first difficulty we find is the lack of consensus on what concretely an implantation failure is. Another step is the confusion about considering some problems inside or outside this concept, such as uterine pathology, advanced age, bad quality of embryos, etc. Trying to make a consensus of many different definitions, we could say that an implantation failure is an absence of pregnancy after at least 3 transfer of good quality, fresh or frozen embryos in cycles of IVF or egg donation. When I speak about implantation failure, I do not mention all the female factors, such as myomas, septate uterus, hydrosalpinx, because I think we must solve all these problems before speaking of a real implantation problem. When possible, the intrauterine abnormality should be corrected and hydrosalpinx should be removed to enhance pregnancy. The process of implantation involves 2 main components: a healthy embryo that should have the potential to implant, and a receptive endometrium that should enable the process. The crosstalk between the embryo and the endometrium is mandatory for successful implantation and normal placentations. As reasons of implantation failure, we should mention quality of gamete, quality of embryos, endometrial receptivity, transfer technique, correct endometrial-embryo interaction, correct phase lutea support, and adequate immunological tolerance. About quality of gamete, both egg and spermatozoa interfere significantly in fertilization rates, in our quality of the embryos, implantation rates, and number of abortions. As we will see later, when all the strategies fail in our goal of achieving a baby at home, changing gametes is finally the best solution, in order to have better quality embryos, which raise enormously our chances of success. When we speak about the oocyte, the oocyte may have some disorders that would compromise the correct development of the embryo. We can divide these disorders in 2 types, depending on the place where we find them: extracytoplasmatically or intracytoplasmatic. There are several treatments described that try to improve the egg quality, such as myo-inositol, also melatonin, and sometimes we also use growing hormone, that in several studies seem to increase the number of mature oocytes. About the spermatozoa, in addition to the usual tests we do for the sperm, about number, motility, morphology, or vitality, we can find some damage in the DNA change that can obviously affect the later embryonic development. We normally do two more tests to the sperm. We do a FISH test, studying the chromosomal defects of the sperm cells, and the fragmentation test, evaluating the possible fractures in the DNA chains that affect the embryo. This fragmentation can be testicular or post-testicular. There is an important relation between the integrity of the DNA and fertilization, implantation rates, and quality of embryos. Here we have some treatments that we can offer to avoid sperm pathologies. MAX is a technique that we use and allows us to select the sperm without fragmentation, increases the chances of fertilization, and improves embryo quality. We can also use PGT-A to select healthy embryos. Sometimes biopsy of the testicle has shown some better rates of fertilization, and some drugs like doxycycline, diclofenac, vitamins, antioxidants. One of the two main players in the equation of successful implantation is the embryo. In fact, this is not an efficient process, as the natural conception rate among healthy young couples is only about 20–25% per cycle. The embryo itself is responsible for at least half of the causes of repeated implantation failure. Some strategies that we could use in order to improve our implantation rates are taking the embryos to a long culture. We must try to transfer embryos in the 5th day of culture in the stage of blastocyst, and we will achieve two goals. It will enable better selection of embryos for transfer and will promote more physiologic synchronization with the endometrium, achieving a better window of implantation. However, the embryo quality, and especially the number of embryos available, may sometimes make necessary to transfer embryos in day 3 of development, when they are in 8-cell phase. Here we can see an 8-cell embryo in the 3rd day and a blastocyst, both of good quality. Second technique that can help us to transfer the best embryos is the time-lapse imaging. Currently, in most IVF units, selection of embryos for transfer is based in morphologic criteria. Nevertheless, modern time-lapse systems provide us perfect conditions for embryo development and much more information about the embryo, such as morphokinetic parameters specific to embryos that are more capable to implant. This technique is nowadays getting more and more importance for our biologists, and every reproduction unit should offer this possibility. Functioning and receptive endometrium is crucial for embryo implantation. Ultrasound examination of its thickness and appearance is an easily performed means of predicting successful implantation. The minimal adequate thickness is about 6 to 8 millimeters. Finding an unresponsive endometrium, especially following surgical intervention in the uterine cavity, is difficult to treat and contributes to implantation failure. Estrogens, low-dose aspirin, sildenafil, E vitamin, L-arginine, or growing stimulating colony factor are described as some techniques to improve the endometrial thickness. Most investigations have suggested that patients with repeated implantation failure may benefit from endometrial stimulation induced by local injury. Performance of the injury induces an inflammatory response that facilitates the endometrium for implantation. Nowadays, there are several tests to study endometrial microbiota to create the better conditions for implantation. A huge number of studies also indicate a major role of the immunologic system in the process of implantation and the subsequent maintenance of pregnancy. A conception must be recognized as a non-self in order to trigger an immunologic process that prevents maternal immune system from rejecting it. The HLA system plays an important role. Also, the balance between Th1 and 2 lymphodes, the antithyroid antibodies, D vitamin levels, celiac disease, antiphospholipid syndrome, immune haplotypes, and many other factors can really influence implantation. Although it's one of the most known factors, there is not enough evidence that NK cells in peripheral blood correlate with risk of implantation failure or early miscarriage. Some of the therapies we have to improve the implantation rates by modulating immune system are the next: lipid emulsion, corticosteroids, intravenous immunoglobulin, antitumor necrosis factor, and granulocyte colony stimulating factor. The treatment with paternal leukocytes isoimmunization is no longer recommended because of the possible side effects to the mother and fetus. Now, before arriving to the end of this exposition, I want to introduce the PGTA technique utility. As you may know, it consists of studying the chromosome of the embryo and allows to select euploid embryos, improving implantation rates, decreasing risk of abortion, and decreasing also risk of chromosomal defects in the fetus. The main indications for the PGTA are maternal age, implantation failure, recurrent miscarriage, and abnormal fish test. We can do it in the 3rd or even in the 5th day of development. So, as a resume of what we must do when we are in front of an implantation failure problem, first of all, we will complete all the studies that the couple needs to discard all the causes of implantation failure, such as karyotypes, looking for translocation, uterine study, ultrasound scan, 3D, hysteroscope if necessary, vaginal, cervical, and endometrial cultures, immunological tests, thrombophilic tests, complete the sperm tests, fish and fermentation, review also previous treatments, transfer technique, quality of embryos, endometrial thickness, and we also have the ERA and EMNA test. ERA test is looking for the window of implantation, and the EMNA test is looking for the ideal microbiota of endometrium. Once we have completed all the tests, we can offer one more attempt with all the strategies involved in improving chances of implantation, such as endometrial scratch, immune therapy, heparin, MAX, time-lapse culture, PGTA. If this last chance also fails, we should consider changing gametes to increase the possibility of getting a viable pregnancy. In the cases we have covered all the possible factors about implantations, and we do not have success in getting a pregnancy, we have to expose the couple the next step in this treatment, changing gametes. This will surely increase our chances of implantation. Depending on the characteristics of the couple, we will offer changing sperm, eggs, or both. Of course, if the main problem is a pathological uterus, we should think of a subrogate pregnancy. About the question when to offer it, it's very difficult to answer when we should offer changing gametes. It simply depends on the couple. It will depend on the age, previous attempts, quality of embryos we get, genetic tests, etc. But if we consider a couple with good quality euploid embryos and normal uterus, we should advise changing gametes after 3 IVF attempts. We would say the same for the repeated miscarriages. One of the options would be to make an IVF with sperm donation. It is indicated for couples with a severe male infertility factor. Of course, donors are tested in karyotypes, blood tests, rare diseases, personal interview, genealogic familial tree. In Spain, it's a completely anonymous process. The second option would be an egg donation. The indications for this technique are increasing because of the age of our patients. It results extremely improbable to achieve a pregnancy without eggs over 42 years old. So the first and main indication for egg donation is maternal age. Here we can see some other indications like repeated IVF fails. We think that 3 is a good number to advise an egg donation. Poor responders, poor quality eggs, fertilization failure, implantation failure, repeated miscarriages, genetic diseases, or menopause. To explain briefly how the process of egg donation works, we must consider a few points. First of all, if we are speaking about fresh egg donation, so we award one selected donor for every patient. By law, the donor must have similar phenotype features to the receptor. Secondly, as we have said in the sperm, it is completely anonymous process. Our donors, by law, must be over 18 and under 35 years old. And last, they pass complete tests similar to the ones we carry out in our patients. I think it's very important to highlight that in front of 40% of pregnancy rates with IVF, egg donation arrives to a 70% per cycle. So this is so that we even offer a pregnancy guarantee program because we are very self-confident about our results. Nowadays, due to the improvement of the techniques, we get also almost the same results with vitrified eggs. Finally, when we offer to change both gametes, we can offer a fresh egg donation plus donor sperm or frozen embryos. I hope I have clarified some of your doubts, and now I am at your disposal for any question you may have.
Thank you a lot for the presentation. Yes, indeed, we will have some questions already now. The first one is, could you please say more about EMMA test?
Could you say more about EMMA test?
Yes, EMMA test is a test that studies the microbiota of the endometrium, we try to get a correct percentage of lactobacillus in endometrium that seems to improve our implantation rates. If we don't have the correct percentage, we can treat the endometrium before making the transfer to increase the percentage of lactobacillus in it. It's under study. It's not still sufficiently validate test.
Okay, thank you a lot. The next question is, what does low NK cells mean?
Well, NK cells are related to implantation failure and repeated miscarriage since years ago, but we should have a correct measure of them. And as I said in the presentation, in spite of that, it's a very common study we do, and it's very known for the patients. It's not demonstrated scientifically that have a relation with implantation failure or repeated miscarriage. However, there are many treatments that are focused, or we do them, trying to correct the NK cells, such as lipid emulsion or intravenous immunoglobulin, just to suppress the abnormal cytotoxic effect of the NK cells.
Thank you a lot for explaining that. And the next question is quite related. Does elevated NK cells on uterine biopsy have the effect of causing repeated implantation failure or recurrent miscarriage?
Yes, it has more relation, the elevated NK cells in uterine biopsy, than in peripheral blood. Some studies say that we should always measure the NK cells on uterine biopsy, better than in blood. But it's also under study. It's not still totally proved. Anyway, we do many actions to decrease the NK cells. Yeah.
Okay, and thank you again. The next question is, please explain a bit more about PGT indication? Thanks.
PGT is it's a discussion we have very often because some of us believe that we should do it almost in every treatment because it just gives us more information about the embryo. It allows to select euploid embryos, so it has with very little damage to them, so it has no black point, but it's still an expensive process. So that's the main limitation. We have to do it. I think. Yeah. Also, the number of embryos. If we just have 1 or 2 embryos, maybe PGT is not so worth doing it.
Yes, and thank you. We will jump to the next one. What are the restrictions of your pregnancy guarantee program?
It depends on what you. We have very many points in the pregnancy guarantee program. We have an egg donation guarantee program, an IVF guarantee program, but the restrictions we have. It depends on the case. We can discuss it individually. I think it's better. We have not common restrictions for everybody. It depends on the couple.
Okay. Janet, you can always send us an email, and I will.
Of course.
I will just put the email address into the chat section, and if you write us an email, we forward everything to Dr. Anaya and Mr. Hermosa, so just feel free to contact us. We will forward every message we will have if you want to ask a question in more direct way. Okay, we can then have the next one. Would you recommend frozen cycle? Is that helps better prepare for implantation?
Yes, it's a possibility. We usually measure estrogens and progesterone before making the transfer. And if they are not in the right measures, we recommend frozen cycle. And when we have failed some fresh cycles, it's another option to try with a frozen one. It helps better to prepare better the endometrium. That's obvious. The pregnancy rates are almost similar. I think that what we win with the endometrium, maybe we lose with the embryo, so it keeps the same pregnancy rates.
Thank you again. Let's see the next one. What treatments do you offer for elevated NK cells?
What we are doing nowadays for elevated NK cells in our clinic is giving corticosteroids as the first line treatment. We also give make lipid emulsion, and we are not doing now intravenous immunoglobulin because of the high cost with no real scientific improvement. It's too expensive to do it without real scientist support.
Okay, and let's check the next one. What effect does high DNA fragmentation have on the quality of the embryos?
Well, I think this is one of the most important things because since we are making the fragmentation study some years ago, we have seen that it's much more important than we thought at the beginning, and we have improved much the implantation, the fertilization rates, the implantation rates, and the pregnancy rates since we make max technique to avoid the fragmentation. It's very important for us. We give it one of the main important points in all this.
Thank you again. And check the next one. Could you tell us about embryo adoption? Do you have this treatment?
Yeah, we do. We do have the embryo adoption. I think it's a good option when you're changing both gametes. Normally, they are embryos that are excellent from cycles from other people. We have to look for an embryo that has the same features than the patient, and it's a bit much cheaper than an fresh neck donation. So I see a good option for some couples. I think it's quite good, and our pregnancy rates with embryo adoption are near 50%. So it's a good option.
Thank you, Dr. Maya. And let's check the next one. What are the odds with fresh and frozen cycle at your clinic? Do you have different success rate calculation for each of them?
You mean in egg donation? Well, we have in the last 2 years we have the same. I think it's 1 point over the fresh cycle, but just 1 point is very small difference. I think we have in the last 2 years it's almost the same success with them. We have also even with vitrified eggs in an egg donation program, we have now increased our rates of pregnancy, and they are very near from the ones we get with fresh egg donation also.
Thank you a lot for explaining this one. And the next one is, do you recommend frozen egg transfer in a natural cycle if the patient has a regular cycle?
Yes, we are doing now many cycles in a natural cycle. We just use the OV tray to make the ovulation, but it's for the rest it's a natural cycle. We have better in some patients. We have very good endometrial thickness, and we have very good results with the natural process. Yeah. But we have to have, as you say, a regular cycle is very important.
Thank you for the answer. And the next question is, I have tested for gluten intolerance, but the test did not show any sign of celiac illnesses, but I had 3 failed IVF. Can it be because I am gluten intolerant? I have a slightly low hemoglobin, but the test showed there is little possibility that I'm gluten intolerant.
Well, I think that if you have tested for intolerance and you are not celiac, just a little intolerance, I think that could not explain 3 failed IVF attempts. It made difficult a bit the process, but thinking that is the only cause of the 3 failed attempts is maybe too much.
Okay, again, thank you for answering this one. And let's check the next one. Do you offer tandem dual cycles with patients' own eggs and donor eggs at the same time? If not, why?
We don't use to do that. And why was just because we think that we prefer to speak with the patient and to explain what is better for her. If there's any possibility of doing the treatment with her own eggs, and we're going to try that, it's a thing. And if we think that she has no possibilities, then we're going to get to a donor program, and we think that should be her treatment. And we have to it's important for her to make her mind that she's going to have donor eggs, and it's not the same. I think to mixture both things is we don't think it's very good.
Thank you for the answer. Let's see the next one. Do you perform maternal spindle transfer in your clinic?
No, we're not doing it nowadays.
Okay, thank you for the answer as well. And let's see the next question. Do you transfer one embryo or two in embryo adoption treatment? Do you transfer the embryo which created from donor sperm or donor egg?
One embryo, two embryo adoption treatment. We can transfer one or two embryos in the adoption treatment. We adjudicate 2 or 3 embryos for the patient, and she can choose if she transfers 1 or 2. We're not transferring 3 anymore. And about the second question, I cannot understand it very well. Do you transfer the embryo which created from donor sperm or donor egg? Sometimes I think that she means that sometimes the adopted embryo comes from a couple, an accident that had a couple, and donate it, and another times it comes from donors. Yes, can be both.
We don't have any explaining for the second part of the question for now. So yeah, thank you for the answering just as you understand the question. And I'm looking for the questions. There's a follow-up to this one, I think. Are those embryo tested for PGD in embryo adoption?
Sometimes they are. Sometimes they are. We could in some cases look for embryo tests for PGD, but not always. Anyway, we could defroze them and then test them if we want.
Okay, thank you for the answer. And here's the next one. Is hypothyroid with TSH at 4.3 a valid reason for 2 miscarriages at 8-10 weeks?
I don't think so. I think that TSH of 4.3 is a bit high. It's a bit higher than we consider the ideal, that is 2.5. But there are several studies that think that even 4, 5, 6, 7 of this TSH, if there are not antibodies, it's not important for the pregnancy. So anyway, it's not the only reason for 2 miscarriages of 8 or 10 weeks. We should treat it to get better TSH, but it's not the only reason, I think.
Thank you a lot for the answer. Maternal spindle transfer is where the mother's nucleus is transferred into the egg cell of the donor after removing the donor nucleus, so the baby is genetically related to the mother. Are you willing to try this procedure in your clinic?
We're not making it nowadays. We're not doing it.
We will follow with the next question. Is fragmentation or 14 a reason for miscarriages? 14%.
No, fragmentation of 14% is okay. Under 35% we consider normal. So it wouldn't be a reason for miscarriages.
Thank you for the answer as well. And I will display the next one. If you offer egg donor treatment, why not maternal spindle transfer? Yeah, it's about the same.
Well, I'm sorry. We're making egg donor treatment, but actually we're not making maternal spindle transfer. I'm not sure why, but we're not making it here.
Yes, and thank you a lot for explaining this as well. Someone is typing a question, so we will just wait a second and until it comes up. Yes, and the next question. I am hypothyroid and on levothyroxine, yes, and as age is 1.2, I am antibody positive. What effect will this have on successful implantation and pregnancy?
Well, you are under treatment with levothyroxine and your TSH is completely normal. I know you are antibody positive, but it could difficult a bit the implantation rate as the publications say, but the effect with a normal TSH is very, very low. And after in the pregnancy should not have any effect. Always that the treatment is correct as yours.
Thank you for the answer. The next question is it possible to find an embryo that is made from both egg and sperm donation and testing for PGD, and in the same time match the phenotype of the patient?
Yes, it's possible. Sometimes it's difficult, but it's possible. We always look to look for the same phenotype. It's not so easy, but we must understand that it's not going to be similar, completely similar, but it will have the same color of hair, the same color of skin, the same eye color, and some phenotype that we can find.
We could try to match as much.
We can try to match as much as possible. We also look to try to look for the same blood group, and sometimes it's possible to find everything, and sometimes we have to sacrifice any of the characteristics, maybe the blood group or the eye color or something, but it's possible. So.
Thank you for the answer. And let's check the next one. What is the success rate of embryo adoption per cycle if only one embryo is transferred?
If I remember it well, I think that with transfer of 2, it's 48%, and transferring 1, I think it's 40 or 41. I'm not sure about that. It's the success rate transferring 1.
Thank you for the answer. And the next question is, what are the success rates for own eggs for 42age patient and the donor egg success rates?
No. The success rates for own eggs for 42 years old are around 5% or less. And with donor eggs, it's about 70%, always that the uterus is normal, if the uterus is normal.
And thank you for explaining this as well. We have the next one. I have a question about ERA test. My beta HCG was 1.7 after a failed transfer. Does it mean my implantation window is okay and the embryo was trying to implant, or it doesn't mean anything? After my 2 other failed transfer, my beta HCG was just 0.
Unfortunately, I think that, in our opinion, the 1.7 is almost the same as 0. So I think it really doesn't mean anything. About the ERA test, the ERA is just a test that is looking for the best days for the transfer, the window of implantation. But if we don't get a pregnancy, 1.7 or 0 is almost the same.
And thank you for your answer as well for this question. The next one is, do you transfer up to 4 eggs in over 43s using donor eggs?
No, we don't transfer. In Spain, here we are in Spain, in Alicante, and in Spain, the law doesn't allow to transfer more than 3 embryos. And we do not transfer 3 embryos anymore. We are transferring 1 or 2.
Yes, and thank you for this one as well. And the next question is, I have had 3 early miscarriages. My husband has very low sperm count. Could this be a cause?
The low sperm count is, in fact, is not the cause of early miscarriages, but as I said in the presentation, we should study better the sperm of your husband about fish test and fragmentation, because sometimes the low count of sperm associate with a abnormal fish test or abnormal fragmentation that could be the cause of early miscarriages.
Yes, and thank you. Morgan, like, I have suffered 3 miscarriages and some implantation failure. Under investigation in London for immune issues and found to have high NK cells in blood and uterine biopsy, but my Spanish clinic told me that immune treatment is not recommended in Spain. Is this the case?
Well, in our clinic here in Spain, also in Alicante, we should recommend some immune treatments, as I said before. We're using corticosteroids, of course, and lipid emulsion is a good chance also to trying to reduce the cytotoxic effect of NK cells.
Yes, and I actually show you this one. This is a thank you for answer. And so, the next question: if the patient has money for 1 egg and sperm donation or 2 cycles of embryo adoption, which one do you recommend?
It's a difficult question. It's not easy. I'm not sure. I think I may recommend the egg and sperm donation, because it's easy that we have enough embryos to transfer and to freeze some of them, so we would have maybe two opportunities in the same cycle. So I think I would recommend the egg and sperm donation for that. But I think also the other is a good option also. Yeah, it depends on the particular couple, in the particular case.
Yes, and thank you for explaining this. Remember that you can always throw us an email, and I just put the email address again. So if you ask this question, we will forward this one also to Dr. Anaya. So just feel free to do that, because it depends on the specific case. So it's good to
Of
ask.
course, we can answer by email or Skype or whatever you want.
And feel free to do that. I don't see any more questions for now, but if anybody has any more questions, it will be, let's say, last minutes to do that. And the question appears: when can we say that NK cells are high?
Well, that's a very, very good question, because as I said in the presentation, NK cells are very known internationally. Everybody speaks about NK cells, and we have many treatments for them, but we still are trying to study if their influence is real and is so important as we thought some years before. And it depends on the laboratory, on the kind of analysis we make. We can study them in an endometrium biopsy. We can study in peripheral blood, and there are several techniques for studying them in peripheral blood also. So it depends on the laboratory.
Thank you a lot for explaining this as well. This is the next one. Encephalitis at a young age can be a cause of infertility.
Can have encephalitis at a young age be a cause of infertility? Encefalitis
Que ella
siendo
tuvo
joven,
una
sí.
encefalitis, ¿no?
¿Puede ser encefalitis a edad joven ser una causa de infertilidad?
Well, if having an encephalitis at a young age could have some side effects, about the correct functioning of hypothalamic and the correct hormone function. But if everything is working properly, I don't think that be the cause of infertility. If she has regular periods and her hormones are correct, I don't think this should be a cause of infertility.
As we don't have any more questions for now, we will be slowly finishing. And yeah, I can once again thank you from the attendees, and thank you also for the presentation, and of course everybody for participation. Thank you a lot, Dr. Anaya. If you have anything else to add, just feel free to do that. If you want to have some final words.
No, I just want to thank everybody for being here with us, and just to remember that they can send an email with their concrete case, and we will be very glad to answer concretely every question they have or they.
Yes, and we will also forward everything we will have from you to Dr. Anaya as well. Also, I just put in the chat section the information where you can find everything and materials and rewatch, and you can follow us or our social media to be always up to date. And we are glad we have you here today, and thank you one more time for today's webinar, Dr. Anaya. It was a pleasure to have you here also, and yeah, have a good night.
Thank you very much.
Thank you very much again. Have a good night, everybody, and see you next time.
Okay.
Bye.
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 Thank you a lot.